Dr. Philippe Uninsky is the Executive Director of the Youth Policy Institute, a not-for-profit evaluation, research, and policy center. He has directed numerous research, consulting, and comprehensive evaluation projects of the juvenile and adult criminal justice systems, violence prevention programming, mental health and substance use services, literacy initiatives, and the professional development of teachers. A principal focus of YPI is to assist governmental agencies in improving the quality of the implementation, monitoring, and sustainability of evidence-based programs serving at-risk children and youth and their families. Dr. Uninsky also founded and from 2000 to 2008 directed the Partnership for Results Incorporated, a model form of local governance that facilitates implementation of a broad spectrum of preventative and early intervention programs, ensures comprehensive multidisciplinary assessments, integrates services, and heightens accountability through the use of interagency databases.
The Partnership for Results is a model of local governance. We've been talking a lot about that, so I think this is in keeping with a lot of the discussions. It was designed to implement a broad spectrum of evidence-based programs to maintain fidelity, to hold the community accountable for youth and families at risk. Over the past decade, since 1999, the program's not only been sustained, but it's proven to be replicable in several communities. But I really want to just point out so that you actually can, we can assert some legitimacy to my conversation, that it's had profound and deep consequences across all the areas that we would normally define as youth at risk. There's been very significant declines, for example, in arrest rates of young adults for violent crimes, at a much higher level than in other state communities. The delinquent JD petition rates, juvenile delinquency petition rates have dropped rapidly. Expenditures on delinquency detention in the county where this model was first implemented dropped 55%. We see massive declines also in uses of alcohol and marijuana. We don't have comparable data for other similarly situated communities. Massive declines in the hospitalization of youth from self-inflicted injuries. Improvements in level of academic achievement. I'm not going to go into these, but if we look at every single level of COM, the goal was to sort of reach them all in terms of violence, self-destructive behaviors, destructive behaviors, and so on. And I think it's also really important to note that every one of these evidence-based programs met and most exceeded the outcomes that were predicted by the validating research. So now, this is a departure from where we've been so far today. The model is based largely on an approach to local governance. I'm not only a sociologist, I'm also an attorney, which means that I can't possibly even say hello in 10 minutes, but we'll try. It's a quasi-governmental entity. It's a 501c3, and there are many reasons for doing that. But its board is comprised exclusively of directors of public agencies in the three dominant areas that are concerned with children and families: education, human services, and law enforcement. It was purposely designed to promote cross-system commitment to what I'd like to call a public health spectrum of prevention and early intervention evidence-based programs. So this includes primary prevention, secondary, and tertiary. We don't have time to go into the definitions of all those. But by promoting resilience and reducing destructive risk-taking and, of course, diminishing the use of restrictive placements, the model's cumulative and human and economic value was quickly established among public agency directors. In other words, it acquired a certain kind of legitimacy which allowed them, both as a matter of feasibility and practicability, to financially redirect funds that were saved into more evidence-based programs, prevention programs, or sustaining the ones that were initially funded with federal funding. I'm going to cover two topics. One is really just what the model generally looks like, and the second one is some lessons I've learned about implementation, success, and failure. The partnership brought a wide range of research into service. We relied on evidence-based programs. We relied on other areas of research, including the impact of using systems in natural settings, systems of care models, which are usually not preventive models, wraparound models, the use of management information systems to improve data-driven decision-making and accountability. And to focus on just one strain of this research, which I'd like to do, I'd like to talk just a minute about how important it was to us at the very beginning, and still is, to understand the prevalence and impact of multiple risks. Prevalence is well established. For example, if you look at recent research from OJJDP, we find that 10% of youth are directly victimized 5 or more times annually in the United States. The CDC's very important epidemiological study, CDC-NP, the ACE study, the Adverse Childhood Experience Study, shows that at least 4 in 10 young people have at least 2 or more significant adverse childhood experiences. There's a growing body of research that unequivocally demonstrates that there's a slide that quite often has nothing to do with what I'm saying. It's just to keep you on your toes. And it works, yes. There's a growing body of research that really clearly shows a very strong relationship between the extent of exposure to adverse experiences and subsequent development of non-normative and destructive behaviors. And there's compelling research that indicates that to effectively address the consequences of multiple risks, responses should be developed early in the onset of problematic behaviors and should be narrowly tailored based on multidisciplinary assessment, and they should be comprehensive responses. And of course, we know that doesn't happen very often. It was evident from the very beginning that we could not find many examples of communities that had implemented a wide range of evidence-based programs in full spectrum. There were, among other, it was very hard for agencies to overcome territoriality. It was very hard for political leadership to see the long-term effect of evidence-based programs, and so preventive investment became an oxymoron for many politicians. And implemented resistance to fundamental social change and behavioral change that comes with implementing an evidence-based program often leads to a lot of resistance to that change. I have to say, because I think it's very important that when we focus on evidence-based programs, that they're not all created equal. Many of them, more than we like to acknowledge, I think, quite often, after initial effectiveness, when they've been replicated, often fail to achieve consistent results. This is some point you made. And they regress to a lower mean. And there are many reasons, I won't go over them all again, but one of them, but quite often the programs themselves are unable to extend the kind of supports for communities that are implementing. They're quite often poorly manualized. And quite often, and this is one thing that hasn't been said, programs quite often extend because they think they need to serve as many people as possible. They extend to people who are not going to benefit from the program. And so what you have is that's a fidelity problem. It's a specific kind of fidelity problem. Now, when we started this, there was very little known about how you implement such a broad spectrum of evidence-based programs simultaneously in a community: education, healthcare, mental health, substance abuse, child welfare programming, family court, and law enforcement reforms. And so we had a lot of questions to answer. One was, can you do this effectively? Another one is, if you create a pipeline of evidence-based programs from primary to tertiary prevention, are effective, and you can have the kind of consequences that we did have in this community, but only if there is a form of local governance in place that provides the essential supports that were discussed earlier: technical assistance, training, ongoing assessment, fidelity enforcement, and so on, and that also maximizes the capacity of each program to serve those most likely to benefit from them. And it's a very unpopular thing to say this quite often, because people say that's cherry picking. But if you have a broad enough spectrum of programs, and they each narrowly specialize in the community of people that are most likely to benefit from them, they not only will succeed and become effective, but they'll actually exceed expectations. We had to develop our own multidisciplinary assessment instruments. I think the model itself has 8 prongs. This is in a lot of literature that's available. You can go to the Partnership for Results website. I think I'm going to try and move very quickly. Nobody's sure how much time I've used. We've developed a checklist, which is a lay tool, which is used to see, without actually being diagnostic, to see how much children are likely to be suffering from certain kinds of mental illness, substance abuse disorders, exposure to violence issues, and cognitive disability short of the IDEA. I'm sorry, that sounds like code words, but I'm not going to explain that. And then that led to effective referral of children and families to a more comprehensive assessment, which went over 37 domains. It's a validated assessment called the Wellbeing Assessment Tool. Now, in order for it not to be far too invasive, we had to use multiple sources of information. And this has been one of the big tricks in getting comprehensive multidisciplinary assessments. You can't expose a child to weeks of assessment, so you have to rely on as much data as possible, have access to recent data. And you need to also train, you need to create a tool that allows clinicians, whether they're trained in mental health or whatever field, to extend themselves beyond their normal discipline-specific parameters. This kind of service, so an essential part of this model is the development of a quasi-governmental entity. It has been every time we've done it. It should be directed by agency leaders from education, human services, and law enforcement. The founding corporate documents, which we can share with you if you're ever interested, I have some cards up here if you want, although I no longer am involved with the partnership, delimit a wide array of the necessities of this form of local governance. There's also a model legislation, as I said, which also outlines this. And one particular area of these documents is that there must be a structure in place for the selection, implementation, monitoring, and sustaining of evidence-based programs. For public agency directors, then this is just basic political theory. Governance, this kind of local governance became an essential and legitimate entity. And it did for several reasons. I'll just name a few. One, they had joint fiduciary responsibility over the programs. Two, there was a person with a gun in the room at all times, the chief of police. No, three, they created a venue for research. So actually, I'm not kidding. There's also the DA was there. Four, with a small staff accountable to all the agencies, the costs of system reform were marginalized. That is, instead of repeating the need, the contraction and all the other activities that need to implement. A basic rule of political theory is that political leaders need to be able to displace blame. We created a whole new agency that took all the blame and they took all the credit. And that's actually a very important thing to do. Our motto in this agency always was, and in all the other ones we set up, was accept blame, displace credit. And it allowed these different political leaders to take on the responsibility of care and nurturing of this organization. See, I'm not even keeping up with my slides. An initial memorandum of understanding, which I would be happy to make available to you, there's also one here in DC for the provision of information. It was with all 23 agencies that serve children and families, and although ICSIC is slightly more abundant this time, all that stuff is still effective and has the force of law. The data was collected from all these assessments for one purpose and only one purpose, and that's, well, three purposes if you like. Comprehensive assessment, treatment, and service integration. Data is not shared unless the consent of the person assessed is provided. So this is a consent-driven system of data collection. You may ask, is that possible? And the answer is we have over 99% compliance when people sign their fully informed consent to provide this data. We have a lot of databases which are designed to facilitate ongoing evaluation. The point I want to make is that this agency is not a single point of access, which is a big mistake that's been made in a lot of system design. It's a single point of integration of services. Now, we developed a public health spectrum of evidence-based programs that were implemented in 6 months. There were over 25 of them, which I'm still very proud of. I'd like to talk a lot about the selection process, but I think I'm running out of time. I just want to say one thing, which is that if people select these programs without understanding the principle of sustainability in advance, quite often they fail. And sustainability is not just about funding and capacity building. It's also about whether or not you're creating the need for a kind of technical expertise that makes the people who are trained portable. I've seen this in many programs. Train public health nurses, they become extremely skilled at a certain kind of intervention, and guess what? They become very highly valued in other communities. Talk about this spectrum, and this is the other half. We're not going to because it's not only too small, but also because you can see this on slides, which I'm going to go to. But I think that what we did here was implement a very broad array of programs that went from primary to tertiary, and when we considered how these were going to be effective, we realized that it was the institutional local governance with planning and coordination supports that allowed these 25 evidence-based programs to be implemented with the speed which we could, which they were implemented. I'm going to just jump right to I think I want to focus and slow down for just a minute. So within a year of this establishment, just 2 minutes. Within a year of its establishment, the partnership became legitimate in the political sense, and that's very important. It became legitimate for all the public agencies in the county, and it did so here in DC. It was legitimate because it became the sole repository of interagency data. It was legitimate because it became the single point of integration of services. It became a single point of accountability. In monthly meetings, all the board members reviewed caseload and outcome data and discussed solutions to emerging problems, which is necessary for the feed and carry of evidence-based programs. A single agency, there it is, from single agency system-specific orientations to one of multi-systemic planning. and coordination are key if you're going to create a spectrum of services like this. The emphasis on meeting state and federal requirements and program standards expanded to include a greater emphasis on achieving particular program outcomes. And in addition, the commitment of agencies to sustaining and even expanding this continuum of programs has led to the development of a new revenue sharing system within each community that's implemented, and has also created capacity for flexible funding arrangements. So if you're going to do this, many communities are going to do this, to wrap up, there are several principles that I've highlighted in order to replicate a model like this, which is a full spectrum model that attempts to achieve all the factors that lead to self-destructive, destructive, and non-normative behavior. First, you need champions from at least 3 public sectors: education, human services, and law enforcement. I think that's pretty obvious. Second, you need a legislative framework for the public figures, for the politicians and the agency directors, such as the one that I've distributed today, and I urge you to look at it. Third, it requires that the agencies change the way they measure effectiveness of prevention programs. So far, in most communities I've worked in, and we need to be thinking about systemic impacts if we're going to value the implementation of evidence-based programs. Fourth, the agency directors who agree to participate in this form of local governance must agree that the selection of evidence-based programs must use highly restrictive criteria, and sustainability must be an integral part of the selection and implementation process. And finally, it's always a key word, the partnership or the model must have a small staff that's available to support the keys to implementing a wide spectrum, and that's data-driven decision-making, externalizing the marginal costs of implementing a wide array of programs, quite often which are quite repetitive, orchestrating training across disciplines, maintaining fidelity, providing technical assistance, and so on. You can go to the Partnership for Results website, which has scholarly articles as well as evaluation studies. The partnership was highlighted by the Interagency Working Group on Youth Programs as an example, a successful example of how to collaboratively implement a broad spread. A copy of the legislation is still available on the New York State legislative website, so it might be useful for other people interested in implementing models like this. Thank you.